Hi everyone. So welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MB Hospital for Diabetes. So today's topic that we're going to be seeing is burden in diabetes care. So when we say diabetes itself, people take it as a burden, but they should understand that it is cheaper treating diabetes rather than spending on the complications they're going to develop due to diabetes. Because most of the people are scared to accept that they have diabetes, so they come to the doctor very late. And by the time they reach the doctor, 50% of their beta cells are already exhausted. So most of them either come with high blood sugars like 300, 400, and they say, last year I was detected with diabetes, but with 1 year I thought I will do diet, I thought I will do something exercise, but then now my sugars are not under control. But what happens is treating diabetes early actually helps us prevent the complication, preserve the beta cells, and actually really helpful for the patient. So today we have with us Dr. Shravil Gadve, and he is actually finished his MBBS from GS Medical College and KEM Hospital, Mumbai. He's finished his MD medicine from Government Medical College, Gwalior, and he's finished his DM from Government Medical College, Guwahati. He is actually participated in a lot of trials, and sir is now the chief endocrinologist in Kolhapur, and he is actually part of all the organizations such as the RSSDI, ADA, the Growth Hormone Research Society, ESI, etc. So on to you, sir.
Good evening, everyone. I am Dr. Sharvil Gadve. I would like to discuss a very important topic today, that is the challenges with diabetes management in India. Can my slides be uploaded, please? Thank you. So the burden of diabetes in India, challenges and solutions. That is what we want to look at. So we know that diabetes in India is a big problem. In India, 1 in 11 adults is living with diabetes. Over 53.1% of adults living with diabetes are undiagnosed. The number of people with diabetes in India is the second highest in the world. 40 million adults in India have impaired glucose tolerance, which places them at higher risk of developing type 2 diabetes. The rise in the number of people with type 2 diabetes is driven by a complex interplay of socioeconomic, demographic, environmental, and genetic factors. This slide shows the prevalence of diabetes in India. Needless to say, be it north, west, south, or east India, the prevalence of diabetes is very high. Probably as you look at the time duration from 2009 to 2019, there has been a steady increase in the prevalence of diabetes in India. Now, what are the challenges in diabetes management in India? We have several challenges. To summarize, we can say reduction in physical activity of the general population, one of the important challenges. Increased availability of processed foods, that is the second challenge. More aging population. So as years go on, we have to take care of more and more of the aging population. Obesity and overweight. The prevalence of people being overweight and obese is rising. That is the another problem. And perception of diabetes is often challenged by some miscommunications occurring in social media. And the knowledge about diabetes, there may be some challenges in distributing or informing people appropriately about the correct facts about diabetes. So these are some of the challenges in diabetes management in India. Now, is there the rural diabetes different from the urban diabetes? Is there in fact a rural urban divide? So that is the big question. Interestingly, a report released by Lancet in 2017 stated that in India, the prevalence of diabetes was almost double in urban areas compared to rural areas. The Lancet study further highlighted that in urban areas, the prevalence of diabetes was higher in individuals with lower socioeconomic status. This was attributed to increased availability of fast, relatively cheap food in recent years, which means poor diets are easily found across in all income brackets. Now, if you look at the distribution of direct cost in diabetes, if you consider the major share is from different things. So, be it disposables, hospitalization, doctor visits, lab tests, anti-diabetic drugs, and other drugs. So, this is the distribution of expense. Now, what are the possible solutions to problems of diabetes in India? First, improved education to alert the population about the risk factors for diabetes would be very helpful. Training of patients to manage their disease more effectively would be important. Development of more structured care delivery is important. Management of cardiometabolic risk factors is important. It is essential to diagnose the disease early and start aggressive management of glycemic factors and associated cardiovascular risk factors. Identifying barriers is very important. Patient-related barriers such as lack of awareness, economic stress, denying risk, all this can be changed with patient education. Rural barriers such as high rates of illiteracy, poverty, different socioeconomic strata need lot of political will to improve these problems. Barriers related to medical profession include medical training focused on acute care. Even nurses find acute illness treatment more rewarding than and better paying. So, better payment opportunities for medical professionals who are involved in chronic care would be a good suggestion to improve care of patients in this field of diabetes. Strategies to manage pre-diabetes would be very important. Imagine that we prevent people from pre-diabetes progressing to diabetes. That would be a very big advantage. So the first step in managing patients with pre-diabetes is to identify them, encourage physical activity, encourage them to have at least 180 minutes of good physical activity, make availability of anti-obesity drugs to obese pre-diabetes patients. Approved drugs presently in India available are Orlistat, Lorcaserin, Phentermine, Topiramate presently not available. Healthcare providers can also consider pharmacologic agents, metformin, acarbose. These two are presently approved. Also, there is a lot of debate on whether we should be using pioglitazone or liraglutide in pre-diabetes. But presently, metformin and acarbose are approved for pre-diabetes in India. If medical management fails to achieve glycemic control, advanced measures such as bariatric surgery can be used with the goal of reversing pre-diabetes and helping the patients who are having extreme obesity. Treatment strategies for diabetic patients. Early initiation of combination therapy would be very important to change the tide of diabetes in India. It is important to achieve glycemic goals earlier. We know there is something called the legacy effect. Novel medication therapies can be used. Now, fortunately, in India, DPP-4 inhibitors, SGLT2 inhibitors are available at a generic cost. GLP-1 RAs are also available. Although expensive, they offer good weight loss benefit. Interestingly, the SGLT2 plus DPP-4 combination for tight control of glucose is now available at a very reasonable cost in India. This particular combination offers the advantage of very less risk of hypoglycemia, better glycemic control, and the advantage of weight loss. So, a FDC of SGLT2 inhibitor plus DPP-4 inhibitor is safe. It leads to rapid and sustained glycemic control, improves both insulin resistance and beta cell function, and now it is overall cost effective. Other strategies which would be important for managing diabetes in India are the dietary interventions. Dietary intervention is a vital element, including low glycemic index foods like whole wheat, brown rice, oats is very important. Avoid refined cereal products like white bread, noodles, white rice, pasta, and so on. Exercise is the most overlooked aspect. We should encourage every individual to exercise. Chronic exercise is important. Regular physical activity is important. And it is important to check the blood sugar levels periodically, either to diagnose pre-diabetes or to manage diabetes. Or anyone who is in remission, it is also important to see whether they have relapsed. So this was all about the present strategies about managing diabetes in India. We have looked at India's specific concerns. So I would like to further proceed with the discussion.
Yes, thank you. Thank you so much, Doctor. So it was actually a wonderful talk. And as you said, because when a patient is actually named or when he's told that he has diabetes itself, he's scared. And having diabetes, and definitely the burden is going to go up because having complications such as diabetic retinopathy, nephropathy, so it's usually better that a patient usually tries and avoids the complication, because treating diabetes is going to be cheaper than treating the complications due to diabetes. And well said, as you told, that preventing diabetes itself is going to prevent the expenses. So pre-diabetes is definitely very important. That is, we intervene at the time of pre-diabetes. Definitely, yes. And obesity being one of the major risk factors, we should definitely try and use anti-obesity agents and metformin, SGLT2 inhibitors, and other things. So we just move on to the discussion now. What are the challenges you personally face in your clinical practice when dealing with a person with diabetes?
So the first problem, what I feel, which all of us face, and even I face, is that the patient is in a denial mode. The moment you tell the patient that, look, you have diabetes, the patient just tries to refuse it. The patient is not ready to accept it. The patient says that, doctor, I have no symptoms. You say my glucose is that high, but I really have no symptoms. So really, do I need to take treatment? So we need to explain this well to the patient that diabetes per se is asymptomatic for several years since diagnosis. Being asymptomatic doesn't mean that you don't require treatment. Your values are high. We have diagnosed you with diabetes. Presently, we use the fasting glucose, the postprandial glucose, and the HbA1c as a modality to diagnose diabetes. So, the first thing I believe that would make a change is educating the population as a whole about diabetes, making them understand that having symptoms with diabetes is not necessary to treat diabetes. Anyone who has diabetes has to be treated well, has to be treated aggressively. We know that there is the legacy effect in diabetes. So the earlier years lost in diabetes, just because there are no symptoms, the patient feels he or she is fine, we lose the time. So we know that there is something called the bad legacy effect. So the changes that happen, actually the changes are happening at the level of the, you can say the epigenetic changes that happen has a long-term impact on both the microvascular complications and probably, yes, also on the macrovascular complications. So educating the people, diagnosing them early, diagnosing pre-diabetes, treating pre-diabetes with all three modalities, that is exercise, dietary interventions, and the approved drugs. Now presently we are fortunate that we can prescribe metformin and alpha glucosidase inhibitors to pre-diabetics as per the DCGI mandate. So all three modalities should be equally encouraged: education, dietary intervention, and appropriate medical intervention.
Definitely, well taken. Because most of the patients at the time of diagnosis itself have lost 50% of their beta cells, because they either try to push to get to a state that, to accept that they have diabetes, or they even delay to go to a doctor. So actually, we'll take up the question from where you said itself, sir. Which kind of patients of set of pre-diabetes would you give metformin and acarbose or voglibose?
So let's talk about a cohort of pre-diabetes patients who are obese and who have a strong family history of diabetes. And we can just take a history of what is their routine lifestyle. So clearly we encourage lifestyle change, we encourage them to exercise, but there are a certain set of patients who really don't follow our advice. So first thing what we should advise to pre-diabetics is that you exercise every day, you do the necessary dietary changes that will help. And in addition, we say that you take this medication. But for a certain set of patients, it is just not enough to advise exercise and dietary interventions. They hardly follow it. So we should not lose the opportunity to use the medical intervention. So I believe we should use both the agents, a combination of alpha glucosidase inhibitor and metformin, no risk of hypoglycemia. Both are very long tested drugs. They have a long legacy of safety and efficacy. Safe drugs can be used for pre-diabetes, and they do help in losing weight in substantial number of patients. The weight loss phenomena is very heterogeneous. There will be a set of patients who will lose weight with metformin. There would be another set of patients who will lose weight with alpha glucosidase inhibitor. And there will be a substantial number of patients who will not lose weight with either of these two. But the one benefit that we would definitely get is retarding their progression from pre-diabetes to diabetes.
Definitely.
Maintaining their HbA1c below 6.5 is an important target. Once their HbA1cs go above 6.5, we all know how difficult it is to get it down to below 7, and even below 6.5, it's very difficult. Rather, it would be more easier to use intervention and to hold their HbA1c below 6.5. It makes more sense. Yeah. So using both the modalities which are presently approved, that is alpha glucosidase inhibitor and metformin. Now we know that for both these drugs, there are some concerns about GI side effects. So there will be a set of patients who would not tolerate them. So there we need to withdraw these drugs. But a substantial number of patients easily tolerate them, they accept it, and we should give the benefit.
Definitely. Point well taken. Because definitely, if we can help them in their pre-diabetes and if we can help them in their weight loss, definitely it is actually better, because them rather turning into a person with diabetes and then treating them, then trying to bring down their HbA1c, this is much more going to be working out easier. Now that we're talking about primary prevention, a person with diabetes, what is the LDL level that you would expect, and when do we start a person with diabetes with a statin?
So now it is very clear. The guidelines are very clear and bold. Every diabetic should have their LDL below 100 milligrams per deciliter. A diabetic who had a coronary event or a coronary event equivalent should have their LDL cholesterol below 70. And those patients who had multiple coronary events and who are at very high risk, if you look at the ESC guidelines, they endorse a LDL level below 55 or even maybe below 40, even very high risk patients. So to summarize, we can say all diabetics should be treated and we should keep their LDL cholesterol below 100. So that is the bare minimum. And depending on their coronary artery disease risk and their past history of coronary events, the target should be further to keep it below 70 or below 55, and in some patients below 40. So we also have the option of using the presently available injectables to reduce the LDL cholesterol much below 40. So these are all the options available to us.
Yeah. Sure. So now that we have spoken about the cardiac safety also in a patient with diabetes, where would you use the SGLT2 inhibitors in a patient with diabetes? Because guidelines now show that after metformin that we can straightly start a patient on SGLT2 inhibitors. So which set of populations would you use the SGLT2 inhibitors, or would you use the insulin sensitizers instead? Or which patients would you use the insulin sensitizers, and which set of patients will you choose to put on the SGLT2
So
inhibitors?
I would like to put it in the other way. SGLT2 inhibitors have such robust benefits, be it the benefit for weight loss, be it the benefit for reduction in the risk of heart failure, be it the reduction of progression of renal disease. So rather, we should look at a way that in whom we should not be prescribing SGLT2 inhibitor. So just considering the factors in whom we would avoid SGLT2 inhibitor, the rest of the patients we should be prescribing SGLT2 inhibitors. Now, in whom do we avoid SGLT2 inhibitors? Those patients who have history of complicated upper urinary tract infection, we should be avoiding. Those patients who have history of past recurrent vulvovaginitis or balanitis in spite of good genital hygiene education, those patients we should be avoiding, because there will be a set of patients who will come back with recurrent problems of infection. So excluding these patients, we should be prescribing SGLT2 inhibitors to most patients, except for maybe a subset of patients whom we identify as LADA. So these are the patients who have latent autoimmune diabetes of adult. They appear to be type 2, but they at very soon they can progress to insulin dependency, and we do fear ketosis with SGLT2 inhibitor use in these set of patients. But apart from this, in the garden variety type 2 diabetes patients who is obese, in whom we want the patient to lose weight. Even a normal looking type 2 diabetes individual will have a lot of visceral adiposity. So we know of the lean fat Indian. So we know that even a normal BMI Indian will have a lot of visceral adiposity if he or she has diabetes. So keeping the exclusion criteria in mind, we should be considering SGLT2 inhibitor to most other patients. And you talked about the insulin sensitizers. Now we have metformin since ages now. So we love the drug, a very good drug, very important drug. To add to our armamentarium, we also now have the drug imeglimin. So we have that another option now available for prescribing to our type 2 diabetes patients. So that is another drug which acts at the level of mitochondria. Never earlier was there such an option available. Now we have a drug which acts at the level of mitochondria. It has a modest HbA1c reduction, I would say up to 0.8 to 1% in some patients, but it's a good add-on where you want to intensify therapy. So all these options are now available. And yes, obviously we are at benefit. We have option of SGLT2 inhibitor at a very affordable cost. We have option of a good DPP4 inhibitor like sitagliptin at an affordable cost. So more and more patients should be benefiting from these combinations.
Definitely. So would you say that adding an SGLT2 inhibitor is always better to add on to metformin, or would you always add a DPP4 inhibitor with the SGLT2 inhibitors just to avoid the urinary tract complications?
Yeah. So very interesting point that you have brought out here, that when we use a combination of DPP4 inhibitor and SGLT2 inhibitor, the risk of vulvovaginitis and balanitis reduces. So that is a very interesting observation. So probably we should be, now we have FDCs available in India, which offer all three drugs. So in a single pill, you can be prescribing metformin, SGLT2 inhibitor and DPP4 inhibitor at an affordable cost, and which gives the advantage of less risk of infection compared to when you use a SGLT2 inhibitor alone. So the combination, I would say, using all three is always good. We have to be aggressive. Always start with multiple drugs, reduce the HbA1c, and then maybe you can down titrate your dose. But starting upfront with multiple drugs, especially for those who are having higher HbA1c, is a much better policy than the age-old wait till you fail and then up titrate. That should not be the case. Yeah.
Hypoglycemia is actually a fear among patients. Once they develop hypoglycemia, then they are finished. Either they don't come to the doctor after that, or they just stop their medicines and they go to these diabetes reversal programs on Facebook, Instagram, because people are promising that they can reverse diabetes for 100 rupees. And most of them go there and they come with a bounce back of sugars of 500, 600 after some 2-3 months, once their starvation and all that is over. So how do we take out the fear of hypoglycemia from the patients?
So at our center, I have followed a practice over the past decade, more than a decade, that at the first diagnosis of type 2 diabetes or any diabetes, type 1 diabetes or any other diabetes, always it is very appropriate to spend at least a few minutes discussing with the patient that now you have diabetes and there is something called hypoglycemia, which you may face anytime in future. So once we educate them, what is hypoglycemia? How do they identify hypoglycemia? And what do they need to do with their hypoglycemia? Once this is discussed with the patient, to my surprise, I saw that patients do really well once they are educated about hypoglycemia. On the other hand, if we have not educated them about hypoglycemia, what you said is really true. They come with a panic state. They fear that something very miserable has happened to them. So the key thing I believe here is patient education, educating them how to identify hypoglycemia and how to treat it. Treating hypoglycemia is simple if a patient knows how to treat it. Right? Yeah.
Yes, because most of the patients we see, they either, if they are in hypoglycemia, they don't come back to the physician because they don't know that if they don't know if it's hypoglycemia, they end up developing a hypoglycemic seizure. They land up to a neurologist. The neurologist tries doing an EEG and they go to MRI brain, and he's on anti-epileptics. And then they go. Then suddenly some people, because of the sweating, they think it's a cardiac arrest. They go to a
Yes.
cardiologist, they do an echo,
Yes.
ECG,
Yeah.
where they just
So,
miss off the simple hypoglycemia.
glycemia. So the best thing is educate every diabetic with about hypoglycemia. Even when we believe that we are prescribing metformin and we know that there is very less risk of hypoglycemia, in spite of that, if we educate them any time in future, whenever these patients maybe take sulfonylurea or insulin and they develop hypoglycemia, they do remember our advice and they manage it well, and that prevents a lot of problems, as you said. Otherwise they end up in ICUs and a lot of other evaluations being done. Yeah.
Yes. Next, when we move on to hypertension, maybe a person with diabetes having hypertension, which is the drug that you would choose for a person with diabetes to treat hypertension, and what are the factors would you look for in a person with diabetes and hypertension?
Yeah. So when we are treating hypertension, especially in a diabetic, we want a drug which has multiple pleiotropic effects in addition to controlling the blood pressure. So the first class of drug which we should be prescribing is uh, either a ACE inhibitor or an ARB. So depending on your choice, you prefer either ACE inhibitor or ARB. When you want to add another drug, it should be either a calcium channel blocker or a third would be a diuretic. Especially we may consider neutral diuretic or rather metabolically neutral diuretics like indapamide. So the chronology is very clear. Start with an ACE-ARB, optimal dose of ACE-ARB, because what offers nephroprotection is an optimal dose of ACE inhibitor and ARB, not a very minimal dose of ACE inhibitor and ARB. And then many patients do require at least 3 drugs. So the chronology is first ACE inhibitor or ARB, second and third would be calcium channel blocker and a diuretic. Beta blockers come number 4 or maybe below that. Yeah, so beta blockers, just because they have issues with triglycerides, they have a lot of other issues. So beta blockers would be not be preferred in the first 3. The first 3, it is very clear. These 3 classes of drugs.
Yes, because definitely patients with diabetes even tend to have the microalbuminuria, which
Yes.
the ACE and ARB tries to reduce the
Yes.
microalbuminuria and in
Yeah.
turn will be saving their kidneys.
Yes.
So we've got these insulins, the basal insulin, bolus insulins, the premixed insulins. So when and where would you choose a patient on basal, premixed, and bolus?
Yeah. So let's say we are talking today about the problems that we face with diabetes in India. So let's say we have a type 2 diabetes patient in whom we want to start insulin because there is OHA failure. 2 options. First, start with a basal insulin. You can up titrate the dose of basal insulin and then you can add a bolus insulin if required. The second strategy is start off with a premix insulin, because it is always simpler for a patient to consider only one insulin twice a day rather than 2 different insulins at different times of the day. Some patients find it very confusing. Although we know that physiologically a basal bolus regimen mimics physiology in a much better way, but when we consider a large cohort of type 2 diabetes patients, there is a place for premix insulin as well in type 2 diabetes because of the convenience of a single device which can be used twice a day. So depending on the patient's situation, the affordability, the availability of insulin, we can choose amongst the different insulins, ranging from regular insulin to NPH to basal insulins to maybe a co-formulation of aspart and degludec. So multiple factors, including cost and availability, would have to be considered before we make a choice.
Yeah, so because mostly people in India, they have high carbohydrate in their diet.
Yes.
So definitely they'll need either a premix because they'll need the
Yes.
short-acting insulins
Yeah.
also.
Yes. Yeah.
So moving into the diet part, could you explain a diabetic diet?
So very important that we educate our patients that a diabetic diet is nothing else but a healthy diet, right? So a very
Portion
easy
control.
way to explain them is the plate method. So all patients understand what is a food plate. So we need to simply explain them that, let's say this is your food plate. 50% of your food plate should be comprising of salads, of green leafy vegetables, of all the fibers in the diet. 25% of your food plate should have carbs, and the remaining 25% should have proteins. So then you can give them different choices as per their local preferences. So the plate method is an important method. educating them that a diabetic diet is not a very different diet. It simply means a healthy diet, high fiber, high protein, low carb diet. Educate them how they avoid refined carbohydrates. Simple things: avoid sugar, reduce your carb intake, increase your protein intake. One thing which problem all of us face in India is our patients have a very protein poor diet. So improving the protein content of their food with whatever is available in his or her household, improving the protein content is very important. That again will further reduce the carb portion. That will also improve the satiety of the food. And a balanced diet is something which is very important. We should probably not be encouraging fancy diets. So there are a lot of fancy diets which people tend to see on the Facebook or maybe on the social media. They come and ask us whether we do this or we do that. But a healthy diet would be a traditional diet with a balance of carbs, proteins, and healthy fats. Yeah.
Definitely. Moving on to the fancy diet, as you said,
Yes.
because what is your opinion on a keto diet and diabetes? Because it's going to be low carb, high fat, or no carb, high fat, high protein diet for a person with diabetes, and this intermittent fasting, GM paleo diet.
Yes.
What is your opinion on these fancy diets?
Yes. So our communication to the patient should be very clear. If they want to follow a keto diet, it has to be done under supervision. There is a lot of risk associated with the keto diet if not done under supervision. There are benefits for each type of diet. Keto diet also has benefit that patients lose weight early, but it is very difficult to sustain a keto diet over a long period of time. So it is always better that patients take medical advice, follow keto diet maybe for a certain duration of time with appropriate changes in their medications, and then again switch to a regular diet. Maybe they can again switch back to their keto diet. So it should be a planned program. They should not be doing abruptly on their own a keto diet, which can harm them. But under supervision, they can judiciously do a proper keto diet if required. Coming to intermittent fasting, the one thing I advise to my patients is that you can do intermittent fasting, but you will have to sustain it. So if they do intermittent fasting, there is restriction of calories because it's time restricted feeding. But we should tell them that you have to sustain it. You need to continue it. If you do it for 1 month and then just forget about it, that won't help. So rather you follow a pattern of diet which you can sustain for a long duration of time. So that would be a better advice, I believe. Yeah.
Yes. Thank you. Thank you so much, Doctor. It was wonderful having you here. Looking forward to having you for more and more sessions with the 4D sessions. Thank you. Thank you so much.